What if I told you fertility struggles are far more common than most people think? What if I told you the conversation around timing, egg freezing, IVF, and pregnancy loss is not just medical, it's deeply emotional? And what if the real power is not in panic, but in information?
Okay.
I'll give you a statement and you'll tell us if it's a myth or if it's a fact, or
Okay.
it depends. If I have regular periods,
Mm-hmm.
my fertility is definitely fine. Myth or fact?
Myth. So the truth is, success in fertility, the most important pillar in that, the most important factor in that is the quality of your egg. Not even how many eggs you have.
Today, we're talking fertility, reproductive medicine, early pregnancy management, and intentional family building with a physician who brings both expertise and compassion to one of the most personal journeys a person can walk. So if you are on your own fertility journey, stay right here because this conversation could change the way you think about hope, healing, and your next step.
This episode is brought to you by 124 Not Out Sports Agency, the #1 agency for international cricketers in North America and the Caribbean. Welcome to the next level.
Welcome back to the Basia TV Podcast. I'm your host, Basia Powell, and today we are having a conversation that is deeply important, incredibly timely, and honestly, long overdue for a lot of people. We're talking about fertility, the real conversation, not just the headlines, not just the myths, and definitely not the shame. Whether you are trying to conceive, considering egg freezing, exploring fertility treatment, healing after a loss, or simply trying to understand your options, this episode is for you. And I'm honored to welcome our next guest, Dr. Sarah Mourik. Dr. Mourik is a distinguished specialist in obstetrics and gynecology with a board-certified subspecialization in reproductive medicine. Born and raised in the Netherlands, she completed her medical studies at Erasmus University in Rotterdam. She later specialized further in reproductive medicine at the London Women's Clinic. And in 2024, she joined the team at the Barbados Fertility Center. Her expertise includes reproductive medicine, hysteroscopy, and early pregnancy management. And she has helped many patients navigate the journey to parenthood with knowledge, innovation, and care. And beyond medicine, which I absolutely love, she's also a former international athlete who represented the Dutch national basketball team. Join me in welcoming Dr. Mourik. Welcome to the Basia TV Podcast.
Thank you very much.
I'm so excited to have you. I can't begin to tell you how many of my friends, when I told them, hey, I didn't say who it was, but I definitely mentioned the type of conversation and the topic. And oh my God, a lot of people were like, yes, you haven't done that yet. You should do this and blah, blah. But before we get into that conversation, I want to tell you I'm a little bit envious of you because one of my favorite places in the world to vacation is Barbados. And you are there and I'm not.
I'm a lucky girl.
You are so lucky you get to be in Barbados.
I know. It's so lovely here. And actually, I had never been to Barbados before I moved here. I accepted this job offer.
Really?
Actually, my husband is from the Caribbean and we were living in London.
Wow.
We always thought it would be great to live in the Caribbean for a little bit. So then this job offer came and I said, we do it.
Manifestation
so far,
at its finest. Yes, that's what you call manifestation at its finest.
Exactly.
I'm so happy for you and your family.
Thank you.
And I think that when I read your bio as we were preparing for this interview, I'm like, Barbados is definitely lucky to have her.
Oh, thanks.
Yes. So yes. So we're glad to have you here today, and I can't wait for us to dive into it. So normally I don't jump into stuff, but we have so much to cover. So
Go for it.
let's start with some context, because
Yes.
I think one of the biggest things people need is perspective, right? So my first question is, in a report published by the World Health Organization, they state that around 17.5% of adult population, an estimate of about 1 in 6 people globally, experience infertility in their lifetime. That means this is not rare. This is not just a few people, because when I hear 1 in 6, it immediately shows how common this is, how it's affecting millions of individuals and couples worldwide. But it seems that many still suffer in silence. So, Dr. Mourik, tell me, and the people listening and watching, and some of them are struggling quietly, from your clinical perspective, what are the biggest misconceptions you see that people have about infertility? I can't wait to hear your perspective on that.
Okay. Well, good first question. I'd like to start with saying that 1 in 6 might be going for like IVF, but in reality, it's more like 1 in 4 who will have some sort of fertility struggle. And actually, recently, another study published showed that women who are highly educated, like doctors, this study was on doctors, but you can extrapolate that, I'm sure, to other highly educated women. It's like 2 to 3 times more than that. So it's absolutely very common. And I think that the most important thing that I want to say to your listeners is that if you're suffering or if you're doing this in silence, just know that you're not alone. Every time somebody starts to speak about their fertility issues, there will be 1 or 2 women in that room saying, you know what, I had the same. Okay, so I don't know. Well, I kind of do know, but I don't want to go like full on in. But there's a reason why we're not talking about it. And it has everything to do with shame, failure as maybe a woman even, which is very heavy to start with. But
but it's the truth.
Why are we being silent about this? This is something we need help with from our friends, from our family, from our doctors. Yet we're hesitant. We're hesitant to talk about it. So I think the biggest misconception is that you're the only one. You're not. It is everybody and
very
their
prevalent.
their aunts in this, not their uncles. Well, maybe their uncles too.
Well, I'm gonna get into that too, because the idea that it's just women, but I don't want us to, we're warming up. As a former athlete, you know how important it is to warm up.
Yes, we do warm up.
Let's warm up. We can't give them everything up front, but thank you. But I really, I'm one of those women who I had other issues in pregnancy. Definitely not fertility. And I'm not saying that because I'm boasting. I'm saying that because I think in a way it came back to haunt me with having too much estrogen in my body and now being a breast cancer survivor, if you know what I mean. I mean, literally, my husband could send kiss and I would get pregnant back in the day. Not now.
Once upon a time.
Yes. But I really want to sit with this point, because many people still automatically assume infertility is a woman's issue. But the World Health Organization, back to them again, highlights that infertility can involve male factors,
of course,
female factors, or both, or unexplained causes. How do you help couples move away from blame and toward a more team-based diagnostic approach or process? And this is a 2-part question for me. That's one. And the second one, do you find it very common that the male in that population who suffers from some type of infertility, do they carry the same level of shame, or do they carry shame at all? The women do.
Right. So when we're talking about infertility, it's basically 1/3 of the times is the men, 1/3 of the times is the women, and 1/3 of the times it's mixed or unexplained. So when I'm going to start with the second part of your question, and then you remind me of the first part.
Yes, that's okay. I'm sorry I'm so excited to get this information out there.
Yes. So Infertility is something that is also very taboo, more in the Caribbean, even so than, for instance, in Europe, where I worked before.
Yeah.
Mm, It is very common, and yet nobody speaks about it. And I just said it's about 1/3 of all the cases where it's the men. But the men tend to think like, I have an ejaculate. Sorry, I'm just going to call it what it is. Okay.
Yeah. Yeah.
Yes. So I have an ejaculate. So, I am not the problem. The thing
Right.
is that the actual sperm cells are only like 1 or 2% of that
Yeah.
ejaculate. So if there is
Low sperm
diminished or
counts.
no sperm, you
Yeah.
wouldn't know. You'll still have an ejaculate. So, and I think the shame for men might even be bigger than for women, because for a man, for a woman to say, look, I'm having issues, it's starting to become a bit more normal, if you will. But for a man to say that, it is starting to become more normal, but here locally, it is a big thing.
So in
for
the
a man.
Caribbean, you would say, because I mean, we're
Yes.
very similar throughout the
Yes.
Caribbean. You'd be surprised to know. We just have different accents, but we're very
Yes.
similar culturally. So you're
Yes.
saying for them in the male population, they carry more shame.
I think so. I think it's very hard. I mean, I think men in general, they don't really talk about their emotions, about their feelings. They do other things socially. So for them to come out and say, look, I have bad sperm.
A weak
That is
sperm count.
perceived. I'm not saying it is. I think they should talk about, but I think they think it's still perceived as not
Bad sperm. Yeah.
Yeah, and not particularly masculine potentially. Look, I'm assuming here, but because I'm not a man, but I'm just saying it's hard for them to, and there's definitely shame. There's definitely shame, and it might be hard for them to speak about it.
And the first part of the question, of course, is how do you get them to have a more team-based diagnostic approach or process?
So when they come here and the couples come here together, they either come to the clinic or we do an online consultation. So it's important that they're both there. We speak about this, and I mention, I explain, because there's often just lack of education. Okay. Let's not say lack of understanding. There's lack of education.
Wow.
So it's not their fault that they're, that not everything is clear from the get-go. So I just explain, look, the causes are often this, and this, 1/3, 1/3, 1/3. And I also say, whatever the problem is, I often say, this is not your fault. This has been with you from birth or often fertility is not somebody's fault anyway. And as a team, you're going to have to
I think that's important
sort it out
for our listeners and viewers on YouTube and Spotify and everywhere, Apple Podcasts. It's very important for them to hear what you just said. It's not your fault.
It is not your fault. Absolutely not.
Yeah. Wow. Oh my God. I want to handle this conversation with such respect, because I know how taboo it is, especially, I mean, this is going to be seen around the world, but our top markets are India, US, and the Caribbean, of course. And, everybody handle, it's kind of like the same. They all feel the same way. You know? So for someone who keeps saying, let me wait a little longer, because this is very important for our millennials and Gen Zs, what are the signs that it may be time to seek a fertility evaluation instead of waiting?
Okay, well, your most important sign is your age. So it's not really a sign, it's just math. Fertility is often like treated as luck, but there is a very logical, mathematical almost background and theory to it. Obviously, there are signs that might make you think, but most important, age. If you are, well, let me say that differently, optimal quality of your eggs ends at the age of 35, 36. Okay. So if you are 35, 36 and you don't have a good idea of your family planning, maybe that is, you don't know if you want to become a parent, or maybe you're just in a new relationship and it's just like not now.
Yeah.
That is absolutely a point to look into your fertility and maybe preserve through egg freezing or embryo freezing. But, and this is my personal passion, because I'm very passionate about awareness and about egg freezing and fertility preservation. So I want to advocate for proactive care. So that means before, so in your late 20s, early 30s, you do a fertility assessment. Okay. How many eggs do you have? How good are they? Because you don't know what life's going to throw at you.
Correct.
And you want to make a conscious choice, because too often I have women or couples in my office, and biology has made the choice for them due to age-related issues. So that is the baseline. And alarm symptoms, if your cycle is irregular, which means longer than 36 days or shorter than 24 days, that is not a normal regular cycle. So you might be having
Wow.
PCOS or other ovulation issues. If you're heavily bleeding, I mean, that doesn't have to do with your fertility per se, but you might have something inside the uterine cavity, a polyp or a fibroid that
Yeah.
might prevent implantation. So your cycle, your bleeding, and obviously there will be the occasional people with early menopause. So if you feel lack of concentration, night sweats, you name it, the menopause is also something that's very much more in awareness these days. Basically anything. Like, we wait way too long before we see a gynecologist. If you think, is this normal? You come and we talk, and it doesn't mean you have to do anything. You're just informing yourself.
Yeah, I'm so glad you raised that, because, as a seasoned woman, a woman of a particular age, not a day over 25, once upon a time, you caught that? Once upon a time, when we were in our 20s, nobody spoke to us about this. And if I had to give advice to any progressive young woman or couple, because it's not a female decision alone, a woman's decision alone, it's a couple decision in many cases.
Absolutely.
But if I were to give a young woman who is not yet married advice, and this is not medical, this is just strategic, right? Because I'm not the expert here. I just wish we had a Dr. Mourik back in our time to tell a lot of my girlfriends and I. As I said, I got lucky. I got lucky that way. I never had to think about infertility, etc. But I know other people who have had those challenges, and it could have been avoided if we had someone on a platform like this or others to say, hey, you know what? You haven't met Mr. Right yet, or even Mr. Wrong, right? Because Mr. Wrong produces children too.
Yes, he does.
You haven't met Mr. Wrong yet. But if I were you, I would freeze those eggs. I think that it's so brilliant. Like, for me, even me, I just wish back in the day, I had a bunch of eggs to put aside. I wish I had the knowledge, because I've never said this before, but in the context of the show, when I was diagnosed with breast cancer, they said, well, listen, because of your estrogen positive cancer, that's like 17 years ago, going on 18, we would like you to, we're going to have to put you into menopause as a part of your treatment. I know at the time nobody was thinking about this, and I had 2 children, but somehow deep down inside, I wish I had preserved some of those eggs.
Of course.
Just for I was like, maybe I wish that because I didn't do it, and if I did it, I would not have done anything about it, but I wish I had the information.
Exactly. And you could make a decision instead of the decision being made for you. Right.
So
and that's
I'm so happy you said that. Yeah.
Yeah, for sure.
So let's talk about age and timing, because this is where fear, misinformation, and pressure can really take over. A lot of people know that fertility changes with age, especially women, but they don't always understand what that actually means in real life. And because so many people hear information late, like what you just shared, then they feel panicked instead of empowered. How do you explain age-related fertility decline in a way that is truthful?
Yes. So here's the truth.
Accurate,
Here
or
is
not
the truth.
fear-based? How do you do that?
So the truth is, as I said in the previous answer, so success in fertility, the most important pillar in that, the most important factor in that is the quality of your egg. Not the quality of the sperm, not the quality of your egg, not even how many eggs you have, the quality of your egg.
So you can have a lot of eggs, but they're just not good eggs.
Well, yes, you could. Yes. Look, let me. Okay, let's first get to that, and I have so much to say. Let's keep it nice and clean and simple, and we go from there. So, egg quality, as I said before, egg quality is optimal until 35, 36 years old. Then it becomes more average. And then after 40, it starts to become poor pretty quickly. After 45, pregnancy with your own eggs is rare. Okay. So let's make this a bit more tangible. Okay. So if I try to conceive naturally with my partner, and I have the right timing, so I have intercourse around my ovulation, and I'm under 35, my monthly chances of conception are around 20%. Okay. So if I have 100 couples and they all try to conceive for a year, so 12 consecutive months, about 70% of them will be pregnant after 1 year. Okay. But monthly, 20% chance. From 35 to 40, I can't really put like one number on it because, it starts to decline a bit. But let's say between 20 and 10, like towards 40, it's going to become 10% per month. Like natural conception after 40 is less than 10%. After 41 is less than 5%. Monthly natural conception. Okay. One thing women tend to do, unfortunately, due to lack of education, what we said before, is that we think if I don't conceive, there is always IVF. Like, because in movies and the narrative is like, IVF is going to solve it for me.
Yeah, I'm glad we're talking about that.
IVF is wonderful, but we are still dealing with egg quality. If your eggs are of poor quality, IVF cannot do a lot about it, and your success rate are going to be on the lower end of things.
Yeah.
So that is, I think, a common misconception about your own fertility, and then potentially solving it with IVF.
Wow. I'm glad you touched on that, because I want to just tell you, as the host of this program, I just don't want to say the wrong thing. And I have never been in that position because of lack of education on this topic. Because you have no idea how many people don't understand the different steps, myself included, the different steps between having viable eggs. And I want us to talk about it because it's a real thing. Having viable eggs and then IVF. A lot of people feel if their friends or their family members are saying, hey, I'm going to Dr. Sarah Mourik at such and such clinic, immediately in their minds, you're having IVF.
Yes. It is also,
are you aware of that?
Yes, also not necessarily true, because it depends on the cause of your infertility. Is it the sperm? Is it the ovulation? Is it the tubes?
Yes.
The original indication for IVF was women with a tubal factor. So the egg and the sperm couldn't reach each other. But so then you would do IVF. But nowadays we do it for other indications as well. I think I want to, if you let me, explain something about fertility that I always, with all my couples, this is how I start, because if you understand this, from there on, it's very easy to extrapolate to all the different treatments and etc. So as women, we are born with all the eggs that we will ever have. Okay. I always say, imagine you have a box full of eggs and it's stored in your ovaries. What happens in a normal cycle is, out of the box, a group of eggs floats to the surface and they become visible like follicles. Okay. A little pocket of fluid with an egg in there.
Yeah.
And in a natural cycle, from that group that floated to the surface, one is going to get ripe and ovulates. Okay. So that one can be fertilized or not. And if you're not pregnant that month, that whole group is thrown away. Okay. So it's not just one egg you use. Float to the surface. Now, what you do in IVF is you give medication and the same group floats to the surface. But instead of the one egg that you mature naturally, we're going to try and mature the whole group. Okay. Now, here is the thing. The medication is not going to create eggs that you don't have. So the size of this group can be 8 eggs, but it could also be 1 egg. And I can give you all the meds in the world. If 1 egg floats to the surface, then that's what you're going to get. So the number of eggs that you can harvest with IVF depends on your ovarian reserve, which depends on age. And this is just about quantity, how many eggs. Quality of those eggs still relates to age. So if I'm 40 and I float 20 eggs to the surface, that's great. Those eggs are still of a certain age, 40 something. So that means each embryo that I create with your 40-year-old egg is still going to only give a success rate of, say, 15% at 40 years old.
Wow.
Okay, so that's a lot of information, but that's like the basis of fertility, ovarian reserve, and even a little bit of IVF.
So now you said something very interesting because I want to go to IVF, right? When patients look at the success rates, the IVF success rates, how should they interpret them in a more informed way? Because obviously now if I'm following you correctly, I'm learning that that's the next step when you can't help them with their eggs, their own eggs.
Depending because the reason I can't help them with their own eggs could be their partner.
Their partner. And what else? What are the reasons?
So, for instance, women with PCOS, they tend to not ovulate.
Right.
So we could try to make them ovulate with tablets. And then sometimes they can just have timed intercourse with their partner. So it doesn't mean PCOS IVF. There are steps in between. If there is an indication for IVF, then, you go ahead. But if it's a male factor, IVF. If there's an ovulation factor, we can try to make that work for you. But if it doesn't work, IVF.
So please pause there for my listeners and viewers.
Yeah.
And me, right?
Yes.
IVF comes into play, if I hear you correctly, when it is a male factor involved, correct?
Yes, but you have a mild male factor, so a little bit abnormal sperm, and then potentially we can do an insemination, an IUI. But if there is, like, I was going to say is severe, but if there is like a real male factor, then that's an IVF. Yes.
So IVF, it's the common misconception for a lot of people. I know this may surprise you because you do this day in, day out. But the common misconception is that women receive IVF because they can't conceive when it's really, they've missed a lot of steps. They don't realize that we end up at that point when it's a male issue in terms of the quality of the sperm, correct?
Right. So to clarify that, so when you come to a fertility doctor, we do a fertility assessment. We see if all the ingredients to make a baby are there. Sperm, egg, and they need to be able to reach each other. Okay. So then we make a diagnosis because it's not just, I have a problem. IVF. No, there is a diagnosis to this.
Before you get to that stage.
Yes. And depending on the diagnosis, roughly, I guess, fertility treatment is two things, right? It's your IUI or your insemination where you inject sperm into the uterus. And then there's IVF. And then before that, you have ovulation induction, which is just tablets to make somebody ovulate. But that's not really something I do to you. That you just take a tablet. As a doctor, I either inseminate or I do an IVF. So the workup is come to the doctor, check your ingredients, get a diagnosis. And then as your doctor, I will say, okay, so your options are A or B or C. And this is the success rate in A, the success rate in B, the success rate in C. And then it's up to you to pick because in the end, it is elective treatment still.
Of course. Nobody's forcing you to do this, but this is what you have to do. But I missed a step because I'm very logical.
That's okay.
In anything any conversation I'm having or anything I'm doing, it has to be logical for me, right? So we often hear, again, it comes back to the shame women carry. So we often hear about, and you talked about it at the top of this interview, where, the quality of your eggs are not as good as you get into those 40s and so on and late 30s, etc. So then is there something that we haven't discussed or we are not aware of as to why we would get to the point where, or I should say, is there like a trend or a clinical trend whereby a man's sperm counts becomes less effective, whether it's in the 20s, 30s? Because we don't hear about that. We just hear that a woman's egg is not good, la, 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 la.
No, so it's not like women. For women, it's very clearly age-related.
So what's the reasons for men?
For men, okay. If you take it, and this is interesting because if you Google this, you will see that throughout time, and this has been very popular, like just a couple months ago, throughout time, you see that men are getting less fertile. Their sperm is less good. And I think the common idea around that is the environment that we live in. Microplastics are like mentioned a lot, but lifestyle as well, stress, alcohol,
What
smoking,
about
not so much.
multiple sexual partners? Does that impact their sperm count as well? I'm just asking.
No, it doesn't.
Okay.
No, it doesn't. Unfortunately.
Yeah.
No, but so throughout time, men are becoming less fertile. And again, it's quite mathematical. Like you give a sperm sample and we will look at volume. So how many milliliters do we have? Then we look at how many sperms per milliliter, and it should at least be 16 million per milliliter. So if you only have 4, then that is what we call a male factor. And that is an indication for IVF.
I'm sorry to be laughing at such important information, but forgive me if I'm being a little naughty, right? But have you ever had a situation where you're saying to, no, I don't need anybody's names here, that's not what we do, but a couple in general, over the years, not Barbados, just in the world, right?
In the world.
And you're telling this man, listen, your quality of your sperm is not up to standard. Have you ever had someone be in denial? Because, men are so...
No. And this, okay. So I'm going to say something because I don't want to be complicit, right? As my doctor, it is my responsibility that, no, I don't. Every time I tell this to a man, they are really sad and they almost feel guilty because they're trying to get, they're trying to have a baby with their woman and it's a diagnosis. Like telling a woman she doesn't have a lot of eggs is a difficult conversation. Telling a man he doesn't have good sperm or no sperm at him is a difficult conversation. It's a
Which
bad
is more
news
difficult for you as a doctor in your experience?
They're equally difficult. But let me tell you something, and this is I think it's really difficult to tell this to a woman, but almost because it's socially sort of more accepted that that a woman is telling it to a man is almost more difficult because
I figured.
And that is wrong. Okay. I should, but this is your unconscious bias. We have like it's so. But I tell you, Basha, it's difficult. It's not. It is. They're sad. They feel shame. It's just
leading into this interview with you today, I was like, I got up really early this morning because I feel somewhat like I was kind of putting myself in your shoes as a doctor, right? And you have doctors, surgeons, etc., who go to work and they treat patients for different reasons physically. I think your job is not only the physical part of medicine, but the mental. You're almost like a psychologist because you have to be gauging the temperature of as you deliver different types of news to people who come to you so hopeful.
Yes, and
is that difficult for you?
Every time I feel that, but because you want to help people and because you can empathize, and personally, I think this is one of the more interesting aspects of my job. And every doctor will have that because in my training, I had to sit like in the ICU telling a family that their father wouldn't wake up because he fell off the roof of his shed on his head. Like, doesn't matter what part of medicine you're in, you're going to have bad news conversations. That's how we call them, bad news conversations. Even when I still did a lot of deliveries, which I love, like labor ward. Every woman is different in her delivery. Some women need a cheerleader. Some women need somebody who's very calm. Like you have to read your audience and you have to bring the news in a way that your audience, your patient likes to receive it. And I'm not always right. I try to do the best I can, but bad news conversations are
tough.
Yes.
That makes sense for every doctor, I would imagine.
Yeah.
So what are the most common expectations you have to reset for first-time IVF patients, especially around timelines number of cycles, and emotional preparation.
Right. As I said before, I think the most common misconception is that they think IVF is going to work. Okay. And then, we get our information. We grow up and we subconsciously build a narrative on things like, where do we see IVF? Where do we see fertility? In movies. Okay. So that's how we think it's going to go. And now with social media, and there are people on social media telling about their experiences. So there is now like, I have a lot of patients who are already quite informed when they come. There's still a couple that have apps, and it's very daunting and they have no idea but in general, IVF is a short treatment. Okay. It is medication for 10 to 12 days, an egg retrieval, and then an embryo transfer 5 days later. Okay, that's when you do a fresh transfer. Or you want to do genetic testing, and then we freeze and your embryo transfer is like 2 months later. But it's not weeks and weeks and weeks of injections. It's quite short.
It's quite short. I'm glad you clarified the duration, because for people, we often hear it's really very difficult. I've had a few friends who went that route in their parenting path, and I was told it's very difficult.
It is super difficult. And not only because having a baby is such a big thing of your future, and it already is not working on your own. So you need to give away that control. It's expensive, so all your hopes and dreams, and there's this huge investment.
Yes. I was going to talk
what about this
aspect.
question? You come at a certain age, your success rate are quite low.
Yes.
Are you going to pay? Are you going to make this investment for a 5% success chance? Are you going to do it? Like, that answer is different for everybody, but it's incredibly emotional going through fertility treatment.
To backpedal a little bit, there's another part of this infertility journey that I don't think we discussed. Before we go to break, I just want to find out briefly, where does this fit in the cycle I feel like there are different steps from what you've explained that can be taken to a successful parenting path. And then the whole issue of surrogacy, like, we didn't talk about that. Is that a replacement for people who are afraid, who are cautious, who are reluctant to do IVF, but they have healthier?
I think we're missing one very important step, and that is donor eggs. So surrogacy is rare. Surrogacy you do if you don't have a uterus, or if, usually these women have tried, and for some reason their uterus can't carry a baby, then surrogacy is the solution potentially.
Yes.
First, when you cannot fall pregnant with your own eggs because of age, because of early menopause, because of an egg factor due to endometriosis, PCOS, the first next step is donor eggs. So you still carry the pregnancy, the egg come from somebody else, you fertilize it with your partner's sperm, that embryo will be put inside your body. Okay, so that is a very, very common treatment with incredibly good outcomes, and nobody talks about it.
And that's why we're talking about it right here on the Basia TV podcast, because sometimes, you look at kids and you're like,
could be not.
Yeah. And obviously that's people's right to keep that to themselves. But I'm glad that we're talking about it in our conversation today, because I'm the type of person, I believe, if you can share something that you've been through with great success and that can help someone else, then help, because you got helped. You know what I mean?
Exactly.
So I'm glad that we clarified that, because that's something that I feel it's not spoken about at all as a part of this big shame under the same umbrella that people can get there by being the mother to deliver that child, but from an egg donor.
Yes.
And that's when the eggs are not viable for the woman. We can get to that stage before IVF.
Yeah. So if the quality, so there's two reasons. Either the quality of your eggs is not good enough, or you don't have any eggs anymore. Then you can use a donor. And it's a very tough decision, again, because emotionally the first thing people say to me is, but that's not my child. Yeah, that's the first thing. But then I say, okay, one thing is very important. Yes, DNA is not your DNA. But if you have a little seed and you put it in the ground in the Netherlands, that seed will grow different than when you put it in the ground in Barbados. So it has the same code, but there is a thing as epigenetics. It will express itself.
That's your tree. That's your tree.
Yes.
It's growing inside.
It is your tree. I like that. I'm going to keep that.
That's your tree. You tell them that Basha said that's your tree.
Exactly.
But one last thing. I know I keep saying last things, but this is so fascinating. This conversation is so fascinating. I think that I have needed answers from a personal perspective, and I'm sure I'm not the only person like this. My viewers and listeners of course, I'm asking the questions that they're too scared to ask, right?
Yeah, good.
So in the same way, you have the egg donor.
Yeah, we have sperm donors. You're going to ask about that, aren't you?
Of course, I'm a little nosy in a medical way,
Of course.
So
And
how is that received by the man? If you say, well, you have the option to get someone, is it normally like a family member or a friend who would do it for them, or just someone generic?
Most people use a sperm bank. And it does happen. You have like your known donors or your identified donors and your unknown donors, which come from the bank. So most people would use a sperm donor from the bank. Most cases where I use donor sperm are either single women or same-sex couples.
Right.
And I'm saying same-sex couples with, I know it's not necessarily the right term, but where there's no men involved in the relationship.
Well, that's what the term we use here in the U.S. because remember, this is a U.S. podcast.
Yes. Okay. So same-sex couples.
Yeah.
Right. So single women, same-sex couples, that's the majority of the donor sperm cases. But obviously there are the cases where there's a male factor where the man has no sperm or the sperm is not optimal. So in that case, we could still try to get sperm from the man through something that is called surgical sperm retrieval.
And please describe that to us.
That is, so you have your PESA, P-E-S-A, and your TESE, T-E-S-E. So I have to tell you something about not having sperm. It has two reasons, right? It is either obstructive or non-obstructive. So obstructive is, there's no connection between the testicle and the outside world. So there's a little tube called the vas deferens.
Right.
Sometimes men don't have that. They were born like that. So, or you might have had infections like measles or anything, and the little duct, the little tunnel got obstructed.
Yes.
So the sperm is there, but it doesn't come out. Again,
so you can surgically remove it once it's there.
So we don't repair the duct or put it up. Then we just get the sperm straight from the testicle. Okay, either with needle aspiration or we make a little cut in the scrotum and take a little piece of the testicle, little biopsy, and then the lab will extract the sperm from the testicle tissue.
What percentage of results do you get with that type of once you can retrieve the?
I mean, this is if it's very different because if it's an obstructive problem, the sperm is usually still good because it's there, it's just not coming out. Again, these men still have an ejaculate. Okay.
Yeah. Yes.
The sperm is just not coming out.
But the sperm stays and other things come out.
The sperm stays and the rest of the ejaculate comes out. Right. When it's non-obstructive, it's often like an hormonal disbalance or and so in those cases, it's often more difficult to get sperm through surgical sperm retrieval. In that case,
I am learning so much today. I feel as though
That's why I'm here.
That's why you're here. You are. I can understand why Barbados grabbed you up. Listen, I feel as though I'm at medical school and I can come join that clinic and give a little advice.
And just work here. Sorry if it becomes too technical. I hope the listeners are like, this is too difficult.
No, it's not. You are doing such a great job breaking it down, but we're going to have to take a quick break. Okay. And when we come back, we are going to break it down some more. Oh my God. Thank you for just making this conversation so simple, not just for our listeners and viewers, but for me too. I've been up for hours just saying, oh my God, what if I ask her the wrong question? But you've made this so amazing. Thank you so much.
You're
it's
welcome.
Your girl, Basha. You're listening and watching the Basia TV Podcast. We'll be right back.
This episode is brought to you by 124 Not Out Sports Agency, the #1 agency for international cricketers in North America and the Caribbean. Welcome to the next level.
Hey guys, welcome back. It's your girl Basha, and I'm hanging out with Dr. Sarah Mourik. And she's really taking us to 101 class
To med
on
school.
med school, right? On fertility. And I am enjoying this conversation way more than I thought I would because I'm learning so much. And that's the reason I want to remind you to subscribe and share this interview with 2 or 3 of your friends. And if you know anyone who would be interested in this conversation today, trying to conceive, a fertility doctor explains, Dr. Sarah Mourik, you're amazing. This has been such a great conversation. But I want to talk about what is hysteroscopy and when is it useful in fertility and gynecological care?
Right. So hysteroscopy is a procedure with which you can remove things from the uterine cavity. Actually, let me show you something. Can we see
Please.
this? Here we go.
Yes.
Right. So this is the uterus, right? This is what it
Yes.
looks like normally. And if you open it, it looks like this. So this inner triangle is where a baby implants. But sometimes in that inner triangle, we have fibroids or polyps or a septum, anything that interferes with this shape can interfere with implantation of pregnancy. So what you do with hysteroscopy, it is a vaginal procedure. This is the vagina here where my finger is. So a small camera goes here, it goes here, it goes here. And then we push water. So your uterus that's normal like this will become, I always say, like a little aquarium.
Right.
And then we can go in with little scissors and we can cut, or a little burner, and we can cut away what should not be there. So you have office hysteroscopy, which you can do under like a minor sedation. But if you have big fibroids and you need a bigger instrument, it is something that has to be done under general anesthesia. And then many women have fibroids that, for instance, are like half, I'm coming back with my uterus, like they're half in the myometrium, so in the wall of the uterus, and then half inside the cavity. So we don't have to remove the whole thing because obviously you'll make a hole in your uterus. We just want to remove that part that's here. So we have something that's like a little grater. So it goes in and it just grates the part away that is interfering with the cavity. So this is a procedure that is done a lot in fertility to remove tiny polyps or tiny fibroids. It's also a procedure that is done for heavy menstrual bleeding. Because if you have things inside your uterus, you tend to have heavier bleeding. So it's a very common procedure done in fertility or, general gynecology.
Okay. When we were doing my producers and I, when we were doing the research for this interview, honestly, it's the first time I came, I stumbled upon that term in medicine. Obviously, we know what fertility, gynecology, everything else is. I'm like, is this like a new procedure or something? Why haven't I heard about this before? Because I had a small fibroid when I was pregnant with my first son, but nobody told me about that.
I mean, it's not new. It's quite old. I guess it's just not a very shiny procedure. When people cut people open, it's more people know about it. But this is done. You don't have any scars. So it's a very minimal invasive procedure, if you will. And then other procedures for fibroids, because I see a lot of women with fibroids, often include cuts where you would have a cesarean section scar. Then we can take everything. It depends where your fibroids are localized. Are they on the outside or are they on the inside? And this is a procedure to remove them from the inside, basically.
Oh my God, this is incredible. Thank you for just giving us all these gems. Like, there's so many people afraid to ask these questions, and they're suffering in silence, and they never get the answers they want because they're afraid of sounding stupid.
Yes.
So to my listeners and viewers, on your behalf, I am not afraid. So you're welcome. So any question that appears to be stupid, I'm asking on your behalf, because I am over my fertility journey, but I still care about humanity. And I want to make sure that the people who subscribe to this platform and they're from all over the world, that they too benefit from learning.
There are no stupid questions. Please
there are
just
no stupid
ask
questions.
every stupid question, please.
So how can you help patients protect their mental health while going through testing or treatments? I know that you're not a psychologist. I'm fully aware, but this is a different type of, the emotions are all over the place. It's
Yes.
one thing to get pregnant naturally, which I've experienced, and for my hormones to be all over the place. And it's another to have a difficult path to reproduction, family life, to whatever you want to call it. How do you help your patients
Yeah. So
prepare
it's
or what advice do you have for patients preparing for this journey mental health wise?
Yeah. So I think the most important aspect is that you try to not do it by yourself. Just it sounds so easy, but find your people. It could be, your parents, your siblings, your friends. It might be a group on Facebook, because there are plenty of like patient groups on Facebook.
Yeah.
And normally I'm not a big fan of like internet, but in this
Support
case,
groups are real
I was
on
gonna say,
such
just like
platforms.
find your tribe. Like, you need to talk about this to some people, and it's hard because
Yeah.
first of all, I want to say that I think you have to be very careful speaking on things that you haven't been through yourself.
Yeah.
Because when I was a young doctor, I saw, for instance, miscarriages all the time in our sort of gynecological ER, if you will, have blood loss first trimester, and I saw them every day. And for me, that was okay. That's gonna take me 30 minutes. So, and then I got pregnant myself, and I got to that like 7-week point, and I thought, what if you miscarry? Like, and all of a sudden it just became this whole new perspective that you have on things. So first of all, I don't want to pretend, even though this is my work and I do it every day, I don't want to pretend that I really know what it feels like. But what I see from my patients is that you need people to help you. Again, you're not alone. It's sometimes a very long journey. It could take a toll on your relationship. It's very hard, especially when you're at that age where all your friends are getting pregnant, or at least it feels like that, and everybody's pregnant around you. And it's just hard. So, and I also think that besides finding your people, there's absolutely no shame in talking to like a professional
Yes, I was
person.
going to ask you about that. Yeah.
We as a clinic, or most clinics, they have a counselor
I would
available.
Imagine. Yes.
That's often available, but it's nicer if this is your own counselor that you have history with, so it just feels a bit more familiar.
Yes, like a family therapist would be recommended. Yeah.
Absolutely.
Oh my God, that is, that's so true. It's important and platforms like Facebook or wherever
Facebook,
you
TikTok,
have support
Instagram.
groups. Yeah, you have.
It sounds a bit like sometimes I'm getting to the age where referring my patients to TikTok sounds like that's not serious. But it is serious. There are people.
We have to keep up with the times. Yeah.
Right. And there are absolutely people that say the wrong things.
Different now for a lot of people.
I think it
however
does.
it comes. So what does truly good fertility care look like beyond numbers and outcomes?
Right.
How can you advise them?
I like that
Our
question.
listeners are, thank you. Our listeners are all over the world, and give them some advice. What does that look like? Where should they start?
Once you're gonna try and conceive, I mean, do the things that you can do that are cheap, that you can do yourself. Okay. So for all the women listening now in their 20s, in their 30s, track your cycle. Download an app that tracks your cycle and start doing it. This is very important data for yourself to have to understand yourself.
Yes.
So that's one. Two, when you start to think about having a baby, make sure you adjust your lifestyle. No smoking, no drinking.
Yes.
Healthy diet. And with healthy diet, I mean whole foods. So try to stay away from the sugary drinks, juices, processed food, physical exercise, mild to medium, once or twice a week. And sleep is very important. So try to get those 7 to 8 hours of sleep every night. So that is the start. This is the basics. Tracking your cycle, doing this in terms of supplements. And this is also, I'm happy I get to talk about this because
I was going to ask you about that from my own personal experience. Now, how important is that folic acid?
Yeah. So The ones you have to take. Folic acid because it prevents from neural tube disease. Okay, so spina bifida, folic acid proven, so evidence-based. Vitamin D. Vitamin D is the next one, I would say, when you think you're low in vitamin D. If you're not low in vitamin D, then you potentially don't even have to take it. And then the third one is omega-3 fish oil. So this is my basic that I advise to all my patients.
Can you say that again?
Folic acid, vitamin D, omega-3 fish oil, not cod liver oil, omega-3. Okay, the basics. You don't.
I think in my pregnancies I missed the vitamin D and the omega.
That's not weird because that is newer. Okay, I don't know how old your children are, but folic acid used to be.
Some adults over here.
Right. No, but this is what I'm saying.
One is an adult and one is soon to be a legal adult.
Right. So folic acid is what you would have been,
Yes.
Medicine always evolves. So the vitamin D and omega-3, those are sort of newer, if you will.
Yes.
Don't buy the most expensive ones, okay? Just your regular smegular prenatal from the local drugstore. Right.
Yeah, that's how I did it back in the day.
Exactly. And that's what you need. But the supplements are important, but it's like getting married, right? A cake is a cake. But if it's a wedding cake,
that, Mourik.
Yeah, if it's a wedding cake, all of a sudden it's 3 times the price, right? We don't need a wedding cake. We just want cake. Okay. So then, if you are in your 40s or you've been diagnosed with low ovarian reserve at CoQ10, coenzyme Q10.
Oh,
yeah,
that's very nice to hear, I'm sure.
Yes.
Yeah, because I only started taking CoQ10 in my 40s because of, the information that suggests that it's good for hearts and all that.
It's not just for pregnancy, but if you're trying to conceive CoQ10 when you're in your 40s and then you have a lot of other, like you can, I'm not going to list all of them because it's so much, but
and of course we'll have you back because I think this, the time assigned for this interview is still not enough for us to go through all. There's so many things I still want to ask you, and my producer's winking, like wink, wink, But let's try and start to lighten up before we go into other segments.
Okay.
What excites you most about serving patients in Barbados and the wider Caribbean international community? Because of course you were coming from a European region and now you are in the Caribbean, and I know that based on where you're placed now, you also get a wider international community coming to the Barbados Fertility Clinic.
Yeah, that's very true. I mean, I love the demographic that we have here in Barbados. I think I can do a lot still here in terms of education and raising awareness on fertility.
Yeah.
That's a global thing, but
It's
definitely still here. We work on some projects with like medical students and just to inform women from a lower age. But like the thing that gives me joy throughout the profession in Barbados, but everywhere is that you can really help these people, like getting that call to say, or getting that email to say that they're pregnant. That is always,
nobody imagine that.
That's always beautiful.
Yes.
For sure. Yeah.
Yeah. And what gives you hope about the future of reproductive medicine? And basically, I want to say, when you look ahead next 5 to 10 years, what are we looking like? I mean, are we going to see greater results, more modern medicine being able to help the reproductive health of patients?
I think the key, like how do you say that? The grill, the holy grail.
Holy grail. Yeah.
The holy grail is to find out how to change quality of eggs so that age is no longer a factor. And there's so much research done in that area. I don't think we're there yet. Yeah, the research is being done, and we have presentations. We're not there yet. There are experimental things where they take part out of the egg and just transfer, so the egg keeps its own DNA. We just put like a little engine in the egg to still work. Is not the right solution yet, but we're working hard on it. So That for me, when that happens, that means age is no longer a factor, and that's going to change everything.
Yeah, well, that's nice. And that gives a lot of people hope. That gives me hope for the next generation, because it's not fair that we were told as women in particular to go to school, get our education, be able to afford a certain lifestyle. And we were trained literally to put off parenting or parenthood. Delay it, not put it off, delay it in favor of a good education, etc., and certification. And then bam, this is what happens. But I want to talk to you about one more thing before we go into the next segment. And that's about you being a former professional basketball player for the Dutch national team. You know,
that seems like another life. It happened though.
But yes, but still it happened. That kind of discipline, resilience, and teamwork that you get from being an athlete, a professional athlete, absolutely says something about how you move through the world. You know, how has that impacted your work as a doctor in this field? Has that experience helped you being an elite athlete? How did it shape you and prepare you for your practice in medicine?
Right. So I became like a member of the national team when I was really young, like 13. And then I played basketball like all through my teens and 20s and even early 30s a little bit.
Really?
Yes. So it was in such a great moment in my life, because where all my other friends were like going through puberty, like teenagers, and going on holidays and drinking their first beer, and I was always practicing. Every school holiday I was in like a training camp, and I was so discipline, teamwork, priorities, all of that, and it was a great experience. Like, loved every second of it. But what it really brought me is that it basically got me into med school as well. So it's something on your CV that not many people have. So it's something that
you got a scholarship. But you got a scholarship?
Yeah, in the Netherlands, it doesn't work like that. So getting into med school is like a lottery based on your grades. So, but then, by the way, I got in based on my grades. I just want to say that.
Yes, of course.
So I went this one way, and then I went the other way, which is like you can sort of apply. They have a limited number of spaces for people who have something extraordinary. So I said, look, I'm an athlete. I can do this, this, and this. I learned this, this, and this. So eventually I was accepted through both ways. It brought me a lot, and I'm very, very fond of the athletic. So my
do you
husband
still play?
Yeah.
Do you still play?
Don't.
Okay, so are you a better basketball player than your husband?
Yes. I like to think so.
Okay, we'll have to see about that. Okay.
He will come on your next episode stating why he thinks it's not the case.
Yeah, So Dr. Mourik, let's do a myths versus facts round.
Yes.
Okay, are you ready?
Yes.
This is
so
a
I want
new
you
one.
To say myth or true. Okay.
Well, I'll tell you what my producers suggested, right?
Okay.
I'll give you your statements, and you'll tell us if it's a myth or if it's a fact, or it depends, one by one. So if I have regular periods, my fertility is definitely fine. Myth or fact?
Myth.
Okay. Number 2, egg freezing guarantees a baby later.
Myth. Sorry.
Infertility is mostly a woman's issue.
Myth.
Number 4, IVF always
myth.
IVF always results in twins. Because you know how much people believe that? I was one of those people. Right.
Myth.
But now I know differently. Myth. Yeah. You should wait a long time before seeing a fertility specialist.
Myth. If you're under 35, a year. If you have a regular cycle. If you're over 35, 6 months.
Got it. You hear that, people? Okay. Stress alone causes infertility.
I'm going to say myth. It has impact, but one, we can't measure it. How does one measure stress?
Yeah.
But I do believe it has some sort of impact, but not enough to, I wouldn't say delay your fertility treatment because you're stressed.
Yeah. Okay. After one miscarriage, something must be seriously wrong.
Myth. Every
Agreed.
pregnancy has 1 in 10 chance of miscarriage, and one miscarriage doesn't mean anything. I
That's
mean,
wrong.
it means a lot, but not for your future.
I understand. It means a lot psychologically, but not
Yes.
that something is wrong with you. Your body just rejected that first one, I guess. That's what I was told. That's been my experience.
It's
Yeah.
not, can I say one thing?
Sure, of
Your
course.
body doesn't reject it. That again, that sort of falls like your body is doing it wrong.
Okay.
You know, like if you have a miscarriage, very often there's something genetically abnormal in your embryo because, you know, you have a sperm and an egg, they come together, that's one cell. They have to copy all the genetic material and divide into 2 cell, copy 4 cell, 8 cell, and so on.
Yeah.
The older your egg, the more likely it is to make little mistakes, and you might end up with a wrong number of chromosomes. And this will not implant or lead to miscarriage. So that's a common, so it's not your body rejecting, it's just,
Yeah.
you know.
So I have to pause here because this happened to me in my 20s, towards my late 20s. And I was told by many people, a doctor, and this, I think I was in the Caribbean at that time. And I was told that, you know, a lot of first pregnancies result in miscarriages. And that's the reason I was given. So clearly that's a myth.
That's also a myth. Yeah. And I mean, look, in your 20s, your egg should be good because you're very young. So
I didn't have an egg problem, I tell you. I don't know what the problem was.
there are still lots of things that we don't know, but in general, it's either genetic or something in the environment in your uterus, maybe increased inflammation. But there are receptor factors and stuff that we as the medical world still figuring out.
Yeah. So last one. Tell me if this is a myth or a fact. Age affects fertility the same way for everyone.
For every woman, not for every man. That's true. Because
Okay.
male fertility is not necessarily as affected by age, but every woman, yes. So
Yeah.
there are a couple, if you let me 1 second. So
course.
having a regular cycle doesn't mean that you're very fertile. I have women in my family who all had babies in their 40s.
Another myth. Yes.
That
They
one.
all had babies. Sorry, I cut you, and what you said was also important. I heard you. I don't know if my viewers did, but I wanted to say that it was a myth because you have healthy cycles. It means that you're fertile. But you made it, you said something about the women in your family. Please continue.
Yeah, so I hear often like I have women in my family who had babies in their 40s. That is not a guarantee. That, you know, that is probably more an exception than, so you can extrapolate that to yourself. The other thing is I live a healthy lifestyle. I never smoked. I go to the gym. I, you know, take well care. No, doesn't guarantee that you're going to get pregnant. So those are the 3 most common things that women, as I say, they overestimate their own fertility, unfortunately.
Wow. That is, I mean, you're dropping some gems here that, I mean, I really appreciate this. I can only hope that the women and even men listening to this podcast on fertility really appreciate what you're saying. So thank you, Dr. Mourik. That message was so impactful. Well, we've had some very intensive conversations around fertility. So now we're going to take a quick break. And when we come back, we're going to get to our segment, which we like to call Last. You're listening and you're watching the Basia TV Podcast. It's your girl, Basia. We'll be right back.
This segment is brought to you by 124 Not Out Cricket Academy, based in Georgia and Florida, USA.
Welcome back. It's your girl, Basia. Now it's time for our last segment with Dr. Sarah Mourik. Okay, so Dr. Mourik, before we wrap up, there's one question I asked every guest who sits in this chair. It's simple, it's powerful, and the answers are always revealing. Are you ready?
I am ready.
Okay. Some guests have said that this is a Miss Universe question. I think it's a human question. So, Dr. Mourik, I'm going to ask you this question that we ask every guest before we end. And the question is powerful, and it's the same question. My final question for you today is, if you could change one thing in the world, what would it be?
Wow, that is a good question. It would be, I'm going to stay in line with what we've discussed in this podcast. And it is that there is education for every woman on their fertility from early age. And it's twofold. So I want that education, and then I want to normalize it. I want to lift the shame. Talk about it, normalize it,
remove the shame.
Remove the shame. So education and more normalization and acceptance of the problem.
Thank you so much. Thank
you.
Oh my God, I can't believe we're finished and we have so much more. You have to come back because
I'll come back. If your listeners have me back, I'll come back.
Once the people ask for you, you're coming back. Dr. Sarah Mourik, thank you for sharing your expertise with such clarity, compassion, and grace. Conversations like this remind us that fertility is not just about medicine. It's about identity, timing, relationships, grief, hope, and informed choices. And the more we create space for honest, evidence-based conversations, the more empowered people can be in whatever step comes next. To everyone watching and listening to this episode, whatever your fertility journey looks like right now, know that clarity is power, compassion is necessary, and hope is still allowed. So whether you are trying to conceive, considering your options for the future, healing after loss, supporting someone you love, or simply learning, thank you for being here. If this conversation helped you, make sure you like, subscribe, and share this episode with at least 3 of your friends. Because trust me, there's someone in your group chat that needs this information and this encouragement, and that needs to get rid of the shame of infertility. Until next time, remember, as I always say, love the life you live and live the life you love. It's your girl, Basia. I'm outside. I'll see you next time. Cheers. Bye.
The views, thoughts, and opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of any affiliated organizations or entities. The content shared is for informational and entertainment purposes only and does not constitute legal, financial, medical, or any other form of professional advice.